Morning and welcome to the third and final day of IPA's Activity-Based Funding Conference for 2021. You already know I'm James Downey, the CEO of the IPA, and before we get going, I'd like to acknowledge the traditional custodians of the lands on which I'm sitting today, the Gadigal people of the Eora Nation, and recognise their continuing connection to land, water and culture. We also pay our respect to elders today and those who walk in spirit. So we've had two very jam-packed days with some fantastic speakers from around the country and around the world, and today's program is no different. And our first session to kick us off is around the impact of COVID-19 on healthcare delivery, and we've got three very eminent presenters from around the country to speak to us this morning, and I'm really looking forward to it. And introducing and moderating the session today is IPA's Executive Director of Data Analytics, who you met yesterday, Julia Hume.
Good morning and welcome to Day 3 of the ABF Conference. I hope you've been enjoying the conference program so far. I'm Julia Hume, Executive Director, Data Analytics at the Independent Hospital Pricing Authority. I'm excited to introduce our next plenary session, the impact of COVID-19 on healthcare delivery in Australia. Co-presented by three renowned experts, Dr. Lucas de Toca, Dr. Emily Kirkpatrick and Matt Page. Dr. de Toca is a public health expert focusing on health systems improvement and health equity. He is currently the First Assistant Secretary leading the COVID-19 Primary Care Response Team at the Department of Health. Outside of COVID-19 work, he is an Assistant Secretary in the Indigenous Health Division, where he is responsible for Aboriginal and Torres Strait Islander child, family and sexual health policy and the development of the next National Aboriginal and Torres Strait Islander Health Plan. He also teaches at the University of Melbourne, where he is an Honorary Senior Fellow within the Department of Medical Education. Dr. Emily Kirkpatrick is the Deputy Chief Medical Officer at SA Health, in addition to the Deputy Chief Public Health Officer COVID-19 Response. Dr. Kirkpatrick is a general practitioner with expertise in population health and preventive healthcare. She's a strong advocate for primary care reform and developing innovative care delivery models. She assisted in the design and development of South Australia's COVID-19 quarantine pathways, providing oversight of the Medi hotel quarantine model. In addition, she has overseen the integration of general practitioners within SA Health as part of the COVID-19 public health response. Matt Page is an internationally recognised expert in telehealth and the delivery of healthcare services through virtual means, with over 2 decades of clinical and service improvement experience in public health. Matt has led a range of system-level redesign initiatives for Queensland Health. He is a keen advocate for equity of access and believes telehealth and virtual care models are essential to achieving the objectives of the National Health Reform Agreement and the future of sustainable, high-value healthcare delivery. We hope you enjoy these valuable presentations today.
Hello, good morning. I hope you're all enjoying the conference so far, and thank you for the opportunity to speak today about how telehealth works in Queensland, how ABF is an integral keystone success factor, and the impact that we've experienced on healthcare delivery and telehealth in Queensland from the COVID-19 pandemic. So as per the introduction, I'm Matt Page. I work with Queensland Health's Telehealth Support Unit. We're a small team of 8, and while I don't pretend to be an expert sorry, bear with me for a second, my presentation just went awry. Always the way, isn't it? You practice these things and then when it matters, you make your stuff up. So yeah, while I don't pretend to be an expert in ABF, the majority of our team have been working together in telehealth for over 10 years. And with this comes an innate understanding of how ABF works, certainly within the telehealth space, but also in the broader system. So the COVID-19 pandemic has accelerated innovation in the way we deliver healthcare services. Queensland was in a pretty good position through having a maturing telehealth program, supported by embedded activity-based funding and purchasing incentives that allowed us to rapidly transition services to virtual delivery. However, while the pandemic response demonstrated the value of alternative models of care to the system and built further confidence in clinicians and patients, moving telehealth and virtual care beyond the boutique, sustainability really can only be achieved through innovative application of activity-based funding and continued work and dialogue with IPA around the alternative models. So Queensland Health, to give you a little bit of background, is made up of 16 hospital and health services. And that includes 4 very rural and remote HHSs, which is Torres and Cape, Northwest, Central West and Southwest. The HHSs are in themselves independent statutory authorities. Of 160 healthcare facilities, 121 are block funded. Then 39 are funded through activity-based funding. The Queensland ABF model differs slightly from the national model. So Queensland uses a Queensland efficient price, which results in a Queensland weighted activity unit, or QWA. So alongside the ABF model, which is embedded funding for telehealth, we also have additional purchasing localizations or purchasing incentives for telehealth. So as well as defining activity targets, the purchasing approach in Queensland is based on supporting the investment in value-based healthcare and comprises of purchasing incentives that apply financial levers to drive the delivery of efficient and effective care. So one of these incentives is the purchasing incentive for telehealth. And so we'll just quickly whip through these, and I apologise if I rush, just in the interest of time. I want to give us a little bit of time to touch on innovation. So we have 4 key program areas in telehealth, and the first one is non-admitted. And that is basically an interaction between one or more healthcare providers with one non-admitted patient, which must contain therapeutic clinical content and result in a dated entry in the patient's medical record. So this is essentially outpatients telehealth. And that consists of a variety of events, one-to-one, group service events and multidisciplinary service events. And the incentive that is attached to that includes a $200 payment for basically activity above the baseline. And in Queensland, we pay both the recipient and provider ends of a telehealth consultation as well. The $200 activity above baseline is restricted to rural and remote HHS and block funded facilities in other HHSs. Then if we move into admitted telehealth, that is basically interactive real-time clinical activity provided to an admitted patient via video conference. And that could be in the form of, say, a virtual ward round or a specialist consult, in particular for the example of, say, a deteriorating patient, to perhaps make the decision on whether they need to be transferred or if they could be managed locally. And I won't go into too much detail here, but there is a provider payment for providing those services into a facility, and the recipient site maintains the DRG or per diem payment associated with the episode of care. We have a new program which is commencing in July called Tele Handover, and that is a formal clinical case conference and negotiation where multidisciplinary teams utilise video conference to provide clinical handover for admitted patients transferring between healthcare facilities. And that will actually attach, will have an incentive attached to it as well for the providing team. And that's $200 for medical officers and $100 for nursing and allied health. And again, recipient site will have the DRG or per diem payment. Then moving into emergency departments, we have emergency telehealth in our program in Queensland, and that is basically an emergency department consultation delivered via video conference, and that can occur across a variety of settings, but in particularly, say, a presentation at a rural emergency department where further advice is sought on how to manage that patient locally. And that includes a payment per medical officer and nursing or allied health officers. And the place where the patient is located gets the URG payment for having that patient there. Lastly, the last program area under our additional incentive payment program is electronic consultations, or e-consult as we're beginning to call them in Queensland. And that is that's the evolution of what was traditionally our store and forward model of asynchronous telehealth. So the transfer of digital images for further specialist opinion. And we have expanded the scope of that to move into e-consults. So that could include, in an integrated care example, primary care, a GP being able to seek advice from the system, from a specialist or other health professional prior to going through with a referral for that patient. And so you can begin to see there's great potential there for hospital avoidance and system optimization. So how did we go over the last year? Just a little snippet of our activity. And zooming in on the dashboard here, you can see we had substantial growth and a very significant increase in our activity related to COVID. However, as a proportion of all activity across the state, you can see there that telehealth is actually a fairly low proportion of overall activity, and there is a large proportion that is actually telephone. So there's a lot of work for us to be done in that space around working out, what is amenable to remaining as a telephone consult and what should come across to video conferencing. And so that's one of the target areas for us this year. And overall distribution of telehealth in Queensland, you can see the vast majority there was not admitted telehealth, and followed by probably mental health, and then admitted telehealth. So there's still a lot of potential room for growth. And then over here, you can see we had this yellow curve here is basically the COVID-19 pandemic response. And while it resulted in a great deal of activity and brought on a whole lot of telehealth naive clinicians and administration officers, what we've seen since, because we've been rather fortunate in Australia in terms of COVID, a bit of a drop down with the system wanting to normalise back to the way we normally do business. So while we did have a great peak in activity, the challenge for us now is to harness that, is to find out, well, what do we need to do to enable clinicians to do more telehealth and to look at alternative ways of seeing their patients. And so that leads to the last bit of my presentation, which is around innovation, and in particular within the context of healthcare reform and system optimization. So we know what's ahead is the addendum to the National Health Reform Agreement has basically set the stage for where our health systems across all our jurisdictions are moving. And that addendum has basically 4 strategic priorities, and I'm sure I'm preaching to the converted here, and many of you will be aware of what those are. But those are essentially improving efficiency and ensuring financial sustainability, delivering safe, high-quality care in the right place at the right time, prioritising prevention and helping people manage their health across their lifetime, and driving best practice and performance using data and research. However, the NHRA and the addendum on its own, while they set the stage, we require levers and mechanisms to actually achieve that. And this is where it dovetails really well with IFA's work, and in particular the pricing framework and the alternative funding models. And those models basically acknowledge the tension between our existing activity-based funding models and the flexibility that's needed to innovate. And I'll touch further on that in a second. And it also investigates alternative funding models, exploring how ABF can be used to support innovation. And it supports the Commonwealth and the states and territories to meet the requirements under the addendum to the National Health Reform Agreement. So what that's resulted in, essentially, the pandemic has accelerated planned innovation in Queensland in terms of telehealth and virtual care models. But these particular models began to emerge, which is remote monitoring or remote patient monitoring, e-consults, which I touched on earlier, and very interestingly, virtual emergency department models. And virtual EDs, it covers quite a broad range of services. And what we saw begin to emerge during the pandemic were things like virtual emergency department consults into residential aged care facilities, as well as a few HHSs set up virtual fever clinics, and also virtual ED models where, say, an ambulance driver presents to a patient's home, they could have a video conference consult with their local emergency department to actually talk to a specialist and involve the patient and determine whether it was best that they come to the ED or they could be treated locally with support of the ambulance care as well as their GP. And lastly, the emergence of true integrated care models, and e-consults is certainly one of those enablers, but we are beginning to see a great desire on the health system's part to work collaboratively with primary care and look at different models that potentially avoid the need for hospitalisation or avoid contact with the hospital. However, what I'd like to leave you with to ponder, and perhaps we can talk about further in this session, is where do we go from here? All of these require ongoing sustainable funding methodologies, and how, as a hospital system particularly, how do we count and report and fund patients who may never actually integrate physically with the hospital? So there are some challenges ahead, but it's certainly interesting times and very exciting times to be working in this space. And that concludes my presentation. Thank you.
Good morning. So I'm going to be talking around the impact of COVID-19, particularly on our healthcare delivery, taking into account our Medi hotel model that we have here in South Australia, and also our vaccination program and where this has impacted across the system here in South Australia, but I'll be reflecting on the national context as well. So particularly I'm going to talk first through around the perspective. So my background is as a GP, and then I've got additional training in public health and other areas of preventative medicine, and have come into the Department for Health and Wellbeing in South Australia to bring that general practice context into the department and how we can innovate in our model of COVID-19 delivery. So I'll talk through around where we're at here in South Australia and what we've done to improve that model, particularly leveraging off the telehealth in general practice. So we know that COVID-19 has been particularly disruptive across the whole sector because it hasn't just impacted our public sector, it has impacted, of course, across general practice, community and disability care, and of course, aged care as part of that. Restrictions interstate, it has considerably disrupted the ability to be able to perform outpatient services, elective surgery requirements as well. So we've in the system and being able to work through that. This COVID-19, we have seen the change in the model of how we are looking to travellers coming into the country, of course, with our national quarantine program that we have in place, each state having a different model of care in which they're implementing quarantine for travellers coming in. So I'm going to talk through around where that's landed us here in South Australia, and particularly what we've done with our Medi hotel, how we funded our Medi hotel, and how we're looking across the system to utilise existing resources. So telehealth has provided us really with this proof of concept as to how we can use telehealth in general practice, particularly, then how does it work then in other sectors, particularly in the community sector, the mental health sector, and then in our outpatient areas as well. Here in South Australia for us with our large geography between our tertiary centre and then out into our regional rural communities, making it more accessible. So particularly general practice has used telehealth very, very well, and we've been pleased to see that the Commonwealth has extended the provisions of telehealth as an MBS funded item. And that's been allowed us really to leverage off the general practice learned skills and how we can put that then into our hotel quarantine system. So we had that temporary bulk billing for telehealth, which allowed us to really flexibly see what was the uptake. And we know there was considerable uptake of the telehealth system, which allowed us then to see, well, where is the community receiving their care from? We know the community general practice, but what can we do in the primary prevention space to move that care out of a hospital system into the primary care space, leveraging off that system that was built in? Yes, and we do know of the impact it has had across the sector, of course, with COVID-19 delays in system care, but we want to make sure that people can see their GP and can see their GP for respiratory-based consults in particular, and the ability of telehealth to be able to screen patients on arrival coming into clinics and then also screen patients prior to getting a COVID swab has been particularly important for us to reduce the number of respiratory presentations into EDs. So I'm going to talk through around what flexibility to do. So it's allowed us to get that greater contact between primary care with the GP, with the community, being able to use these MBS items, but also think around how can we be more innovative in our model of care? Can we consider awareness raising campaigns linked with MBS item numbers? Can we consider how we can move care that would usually be in the outpatient space with particular allied health practitioners into our general practice setting? And particularly, we're keen to see how we can get regional rural health more involved in the system, leveraging off our existing metro urban-based care products. The next area I'm going to talk through is around our Medi hotel costing, and this is where this links in with the telehealth item numbers and where we saw our Medi hotel taking off. So South Australia of international arrivals on the 21st of April last year. So we're over our 1-year anniversary, and so far our model has been quite successful, which is good to hear. Fingers crossed that continues. We have 5 Medi hotel sites across metropolitan Adelaide, and then we have 1 dedicated facility that we've established, which is for our COVID positive patients. Now, the model of care that we have developed with our Medi hotels is it sits within our department, so operationalised out of the department, not within one of our works. We've built our structure within our departments. Our executive director, our DP reporting in, our clinical governance sits on the side of this model to inform the care and make sure that we do have those very strong linkages with our operational arm in the department and also with our primary healthcare response and our public healthcare response. So it's been quite an unusual structure to very quickly develop what we would call a mini hospital structure with the reporting aspects, the clinical governance, having that high level executive making strategic decisions as to how we see our Medi hotel forward. And we've certainly based it on a wellbeing wellness model. So every patient or every traveller coming receives a GP consultation on arrival. They're prioritised in categories of 1, 2 and 3 based on urgency up to 72 hours after arrival. And initially when we started MBS telehealth item numbers to try and remove some of the back into the Medicare system. But unfortunately, we found a large number of people did not have active Medicare cards and did not have or had not been in Australia for many years or were coming on different visa statuses. So it was very hard for us to be able to then bill Medicare, and it caused a gap in our system. Of course, we didn't want to start charging the travellers coming in, many of these people being very vulnerable coming back into Australia. We didn't want to have to charge them for their medical care whilst in quarantine. So what we have done instead of that is moved away from the Medicare funding and have moved those telehealth item numbers into a contractual basis with a GP locum organisation who provides those services on an hourly rate for us at a 24/7 model, which has been very, very helpful for us, particularly as we've seen such complexity of our patients coming in or travellers coming into our Medi hotel system. The other aspect has been around mental health, and we know individuals have been, for many, have been stuck in very, very difficult situations overseas and have had to rely when they come here into Australia on strong mental health support and being able to have regular follow-up with a clinician. So for every traveller coming into South Australia, we've now implemented a model whereby everyone gets a K10, so a mental health screening assessment, and also has a consultation with a mental health practitioner if they reach a certain threshold in their K10 scoring system. Very early on at our model and do comparative studies between the mental health scoring systems to see whether we in fact were meeting the needs of our travellers coming in. Very, very difficult then when you try and reclaim back costs for this model of care. It's predominantly a state-funded system, Medicare funding, or particularly through our hospital funding if individuals don't have Medicare cards. So this sort of came back to our heavy reliance on telehealth and trying to pivot and transition to a contractual activity funding where we did not have that Commonwealth Medicare support coming through, and it was state-based funding. So what have the costs been for us here in our system? So we know our model is incredibly intensive from both a resourcing workforce perspective, and it is very hard to get workforce into our hotel quarantine system. No doubt people see the risk associated with that, but there's been little that we can recruit here in South Australia 3,500 in quarantine fees per traveller coming in, and we know a number of people do get exceptions to that based on their own financial position, and so there are ways for exemptions around that. But apart from that, it's well below what the services are that are provided. When we undertook a comprehensive review of the costs associated with our quarantine system, we were sitting at around $8,900 per person. Now, this was back in October when we undertook a cost analysis, particularly for our cabinet submissions, to be able to obtain additional funding for the model of care. But since October, there have been considerable changes to what is considered best practice and evidence-based practice for what is required in a hotel quarantine system. We know hotels are not designed to be quarantine locations, given the number of modifications that need to be offered to make them safe, to contain that risk of disease transmission. So for us here in South Australia, modifications on our system, which came into effect after November, so after we'd done that costing back in October. And those modifications were making changes to our heating, ventilation, air conditioning systems within the hotels. We had to block off particular rooms, so therefore reducing what ability we had to put travellers into certain hotels. We had to make considerable upgrades to our security systems, to CCTV. We had to install new CCTV systems across our hotels, which had artificial intelligence to be able to track movements on floor, trigger lines that when people opened their doors, it would then trigger the CCTV system. Now, all of this was around reducing staff on the floor, reducing the risk to security personnel on the floor. But of course, with all of these modifications has come an exceptional amount of costs coming through a system where it sits within the department, not with an LHN, so not utilising existing funding within the LHNs. So it has been considerable cost for us moving forward in this model of care. We're currently at a point now where we're looking at the next 12 months moving forward and analysing where we can become more efficient in our costs. And particularly, we are focusing on where we see telehealth and other roles for that non-face clinical care can be incorporated. So we're currently looking at investing in different models where we can put iPad technology into rooms to be able to have that greater face-to-face contact, reducing the number of personnel that we have on site, reducing that risk of exposure to our staff working in the quarantine system. So that's really around where we see the Medi hotel costs. Considerable, the fact that it is coming out of our state-based funding. It's very hard to reclaim through our Medicare costs, particularly if we don't have individuals with Medicare cards. Certainly our dedicated site that we've set up, which essentially mirrors another small hospital, how we've established that in Metropolitan Adelaide with just dedicated positive beds. So we have a 33-room Medi hotel that's been established in Metropolitan Adelaide that allows us then to put our positive patients. We have seen this significantly improving our care model. It means we can move individuals out quicker out of the hotel, have rooms cleaned quicker, and we know that that reduces our risk of causing disruption to the system by not having someone with COVID positive sitting within a hotel of others who are not positive themselves. I'm now going to talk through our vaccination costs, particularly around the GP aspect of this, which is where I come into the department role. So we know that general practice really is the most ideal sector to roll out vaccinations. This is bread and butter work for general practice to undertake. We have that great care relationship between an individual in the community and also with the practitioner. So we know that's where you get that really informed consent, that discussion around what are the risks and benefits of vaccination, ability for follow-up. So very pleasing to see specific item numbers for COVID vaccination within general practice, and ease of access as well for GPs to be able to start vaccinating and using the COVID vaccine within their existing infrastructure. But we do know that there are high costs associated to give the vaccine, extra phone calls, more time with patients, and particularly as we've seen a change of the system in terms of our breaking and changing the AstraZeneca-Pfizer age breakdown and moving towards that, it has taken considerable time for our ability in general practice to be able to consult, inform consent and move forward. From a we initially were in the position that we were moving as much care as possible into general practice, so we had that relationship with the patient and utilising our hospital-based clinics for those higher risk individuals and our staff within our hospital sector. However, what we have seen now is a shift towards having state-based vaccination hubs. Now, it's quite simple really from a recharge point of view. We get a set amount per vaccination given based on a metropolitan rural regional location. Of course, we work through that with the Commonwealth in our partnership agreements as to how that looks moving forward. But it's a relatively simple funding model. We know how much it costs per vaccination. We can time out how long it takes, 8 minutes with a vaccinator, 45 minutes in total in a clinic, and we can model out what are the economics behind that. But from our state-based perspective, we see that relatively straightforward moving forward. What we do find more challenging, of course, is the vaccinations with our regional rural areas, and that's where it comes back to the work of general practice and being able to utilise existing sites and existing MBS funding to ensure we can vaccinate our communities out in our more isolated areas. And of course, we know that vaccination is that very, very important tool which will then help us overall with our COVID-19 response, impact on care delivery that we've seen, the disruption that COVID-19 has brought to us. And of course, the Medi hotel model we know will continue for some time, but we hope vaccination will assist in how we look at alternative models, more cost-effective models of quarantine moving forward. And of course, innovation. So where does this lead us now? Where do we see the state-based system heading in terms of the Medi hotels, the vaccination? How can we leverage on? So as mentioned, we are looking at more innovative solutions to partner with the primary care space. Of course, we often sit quite siloed within our departments, don't have that in-reach into general practice primary care to see how we can partner better on hospital and the home projects within primary care preventative space and reducing those admissions, presentations, and of course treatment within our tertiary centre. So we are looking at how we can become more flexible in terms of our approach. Of course, general practice locum services contracted in. I found this on the web. Oh, that's my watch. Contracted locum GP practice provide services into our Medi hotel, not utilising existing hospital-based resources or medical consultants within our hospital system has been a very successful model for us, particularly as the GPs can provide very comprehensive primary preventative healthcare and be able to bring the mental health support aspect in as well. So as we rethink where we see ourselves heading and where we see ourselves becoming a safer model of care in terms of our Medi hotel model, we certainly see the role that funding additional CCTV within our hotels has allowed us to create that safer model of care from an infection control perspective. Of course, we don't usually fund CCTV within hotel systems. It's quite bizarre of health to be doing that, but we know how vital this is to be able to reduce the risk of an outbreak, reduce the risk of us requiring restrictions here for our state, and then of course reducing that risk of community spread of COVID-19. So all about reducing risk to the state by funding into our Medi hotel system, but of course we need to be more innovative and think how can we leverage off other resources in our existing healthcare system. And one final thing to mention is just around our AI as well. One of the areas I was really keen to see progress was how we got information out to the community. And so by having AI technology, particularly on our website, the ability for a bot there to ask questions, to be able to get reliable information has been so important for us. So we have a public information team who have done a fabulous job at making sure we can put out the most accurate, reliable information, and using that AI been incredibly helpful for us, leveraging off our existing website and increasing the number of clicks that we have online. And as we move forward and we think, what are the next steps, particularly in my role as I work as Deputy Chief Public Health Officer and Deputy CMO here in the department, it's considering how we can experts from the primary healthcare space and ensuring we are leveraging off all those existing minds who understand the system so well in that primary space, and not always thinking we go back to the tertiary system, always thinking we need to be in the outpatient space, need that ED environment. So thinking around what are the future healthcare needs of individuals coming into the state, and how COVID-19 a disruptor, but at the same time make it a productive disruptor. All right, I will leave it there. Thank you so much.
Hello, thank you for having me. I'm Lucas Toca, and I work in the Department of Health in Canberra, leading the primary care response to COVID-19, which now includes for my sins, the rollout of the vaccine through primary care. So it's good to be in this conference, and good to see Emily and others that we've liaised with throughout last year in the COVID response. I'm here in Ngunnawal country, so I want to acknowledge Ngunnawal Daura, Wangaralijinyin, Marin Balang, Bugrabang, and extend that acknowledgement to the traditional owners of the lands where people may be viewing from. I feel like a bit of an imposter in this conference because my role is sort of wrangling public health systems, and there's been a lot of innovation around COVID and primary care, but I'm not an AF expert, and unfortunately, my information is not going to be as or expertly informed as Matt's, but hopefully it'll give a bit of a picture of some of the changes that have been happening in primary care nationally, which correlates really well with Emily's perspective from the SA, both GP and SA Health look on the ground. So hopefully this works. Yeah. So with as you all know, crises are great catalysts for innovation, as has been the theme for my colleagues' presentation. And there was a number of things that we needed to activate from very early on to protect and preserve the primary care system so they could continue its fundamental role throughout the pandemic without further impacting on or disrupting service delivery. It was very clear from the late February, early March, when we were designing the whole of health system response as the national response was coming in, as the national response coming in with border closures and biosecurity declarations, was what we needed to do from a health system to minimize the impact of potential COVID on overwhelming healthcare provision, like we were seeing was starting to happen in Europe and other parts. So we were essentially preparing for the worst, and that's why we tried to build a system architecture with a package of reforms that was announced on the 11th of March that would help cohort or preserve different streams of care to allow for normal operations to continue with minimum disruption, while acknowledging that there was going to be a significant shift on healthcare behaviours and with introduction of lockdowns, etc. So we thought that there were a number of changes that needed to happen, as my colleagues have seen, have mentioned. Telehealth was rumbling for a while. There was present in some parts of the system, but it was part of the sort of 10-year primary healthcare reform plan drafting. But it was accelerated. The minister often talks about 10 years in 10 days, and that's what we did, with introduction of about 6 different tranches of telehealth items, starting from that very early mid-March, to be able to continue care as much as possible without exposing or risking their practitioner and the patient. The whole idea was to try to preserve the vulnerable people enabling them to stay at home, things like telehealth, etc., but also to preserve healthcare workers and protect healthcare workers so that they could continue to provide that care. So we introduced telehealth. We expanded the national triage hotline, the Health Direct, and similar provisions in the states that have their own, so that there was this shift from face-to-face to tele in all parts of the system. There could be a centralized triage system that allowed for people to find care in the right locations. We understood that even though there was more and more testing available through state facilities, there was still a gap on a high number of GPs, particularly older practitioners who were no longer doing face-to-face because of risk to themselves. But people would still need to present with respiratory symptoms and would still be needing a face-to-face assessment. So in order to divert that group from emergency departments and specifically cater to a subset of the population that would be having the need for a face-to-face respiratory consultation and a COVID test, but couldn't just go to a drive-through COVID testing facility because they needed to have that GP-led assessment. We established a network of 150 GP respiratory clinics, of which the majority are just shy of 60% are located outside of regional and rural areas. Initially as a pilot, and now they've been extended and now transitioned to also offer vaccination services. We also included and made available from March 16th, so very early on, infection prevention and control training for healthcare, aged care and disability care workers, and then we added a number of modules to support those specifically for aged care workforce, for Indigenous health settings, including remote settings, and a number of specialized modules to facilitate more in-depth training. We fast-tracked electronic e-prescribing and home medicine support. So again, so people who could not or did not want to access healthcare through face-to-face could still receive the script and medications. And again, that was always in the cards, but was very rapidly catalyzed because of the need. And we also understood, and I'll talk about this in a bit more depth, the need for flexible approaches that could build into the sort of blended payment model that Aboriginal community controlled health services already have, understanding that there was a high risk in a potentially very vulnerable or at-risk nations communities because of the existing burden of disease and the experience that we're seeing overseas with other Indigenous populations. So overall, we were trying to do that segmentation of care throughout the system to preserve its normal functioning while pivoting to a less reliant on face-to-face type of model. Telehealth was incredibly successful in its adoption. We've had 56 million MBS supported telehealth items since it started in March to over 13.6 million patients, and a significant injection of funding from the Commonwealth Government to complement also the National Partnership Agreement that was established with the states, by which 50% of all COVID-related costs, including Medi hotel, etc., are paid for by the Commonwealth. Very good adoption from all types of providers for telehealth services, with a majority of practices, pretty much all practices, transition into some or all telehealth appointments, and now thankfully face-to-face appointments have returned, but for a while a significant proportion of practices were only offering telehealth services. It's been signaled that it's clear that it's going to stay. At the moment, the telehealth items have been extended as they are, with a number of small changes till the end of December. But in the context of the primary care 10-year plan, there's an understanding that different payment models and different funding streams need to be catered for, and there's a commitment to continue telehealth after the sort of acute COVID items themselves. But that's part of the sort of long-term primary care reform approach. I just wanted to touch base on a sort of a case example for us of how flexibility in our approach as a government, and noting that the Australian government or the Department of Health has only a number of fairly blunt instruments for supporting localized responses. We don't generally do service delivery. That's something that the states and territories do, and they're much better at it because it's their bread and butter. We have a number of regulatory levers, and we have a number of funding mechanisms, but we're always at arm's length from delivery. So our ability to rapidly change things to support responses on the ground was seemingly limited, but we did have a pretty significant capacity to exert change through our direct relationship with Aboriginal community control health services across the country. So there's about 145 ACHOs, or community control health services, in Australia that are directly funded by the Commonwealth, and with some support from the states and territories, but we have direct contractual relationships and grant systems with them, as well as supporting a very well-established network of sector support organisations, or state and territory and national peak bodies that provide not only representation and advocacy for the ACHOs, but also support, continuous quality improvement support, and overall act like a sort of a network sharing quality improvement and lessons learned. So we relied on that existing relationship, and in the principles of the soon to be, because it was signed on July last year, and on the final stages of the draft of the refresh closing the gap agreement that all governments entered with the Aboriginal representative sector last year. And with those principles, we entered a formal partnership with the Aboriginal community control health sector and Aboriginal leaders for the establishment of an advisory group that essentially, that was formed on 5th of March, so very early on, and essentially drove the formulation of all the response when it comes to First Nations communities. Another strength of that advisory group is that it had representation from federal and state and territory, both government and community, everyone around the table to make informed and well-discussed advice to all governments on how the First Nations aspects of the response had to be implemented. We based the principles of that response in the closing the gap prior to reform agreement new principles, so that we had that open share of data, shared decision making, and not just consultation after the policy, community control at the centre, and of course our human rights framework and cultural safety, which enabled us to do things that would have been unprecedented or considered to be quite intrusive, like utilising the biosecurity determination with unprecedented powers to place restrictions to access on remote communities. That essentially covered 26% of the Australian landmass. That was successful as opposed to being seen as an imposition in communities, because it was following advice from communities that wanted this to happen. And in fact, Emily will recall well that the AP Wildlands used the within systems to limit access to their own communities. So the federal government simply used its powers to put into effect what the communities were asking for. But the other thing that we did was flexibility of the funding provided to ACHOs, and ACHOs are a little pilot. We always some ACHOs have participated in the, for instance, healthcare homes model, but ACHOs in themselves are already a mini healthcare home. They're integrated comprehensive primary healthcare providers that are funded through a blended mix of grant payments, some specific programs like tackling Indigenous smoking or renal programs, but overall quite broad and core primary healthcare funding that can be used to tailor to local solutions, but also with an exception to Section 19(2) of the Health Insurance Act, so that they can also bill Medicare, and about 10 to 15%, and some matches up to 30% of their funding is through MBS funding. So this mixed approach allowed us to inject some further flexible funds through the ACHOs, through NACHO and the representative bodies, because we have a direct relationship with them, and then these sector organizations had more flexibility to then administer the services as they were needed. We could provide flexibility to the use of their grants so that they could target their funding to what was needed without necessarily sticking to the pots or the buckets of discrete funding that they would normally have to adhere to, and then of course benefited from all the other MBS, telehealth and relaxation arrangements that were set up for the overall system. But it was only through that mix of different payment systems that actually enabled them to react and pivot so flexibly, even before additional cash or telehealth changes were put in place, with ACHOs preparing for the response from early February, even before some of the formal federal government activation systems were put in place. So to us, has been a really successful model of building on existing relationship, partnership, and trust, but then enhancing it through the crisis situation, and cemented that sort of mix model of payment for comprehensive primary healthcare allows for a significant capacity to respond flexibly to local need. That is something that in this context has been really useful, and I think members will be familiar with the outcomes so far of the response, by which First Nations people in Australia have had a rate of COVID-19 6 times lower than general population, no deaths, and only about 150 cases in total, which is unprecedented compared to how Indigenous communities have fared with COVID-19 internationally, let alone our own usual health outcomes in Indigenous health indicators. That's probably all from us. And note that we are a little bit behind time, so probably better to go to the Q&A.
Thank you, Lucas, Matt, and Emily, for your presentations. They're all fantastic and covering quite a broad range of issues which have been addressed by all jurisdictions, or many jurisdictions across Australia over the past 12 months in particular. And so there's been a number of questions come in. Quite a few of them have been around patient experience and patient outcomes. And I suppose if I could ask you all, with the increase of telehealth, have there been steps undertaken at the moment to understand the impact on patient outcome, patient experience, and possibly also the clinician experience as well? Matt?
Yeah, look, I mean, that's a great question, and yes, indeed, there has been. That's an area of great interest for us from our program perspective. Up until recently, we've been focused on growth and numbers, but we really haven't had any visibility or insights into what is the quality of the care delivered through telehealth and virtual care means. So that's an area we're working on at the moment. We're looking at prems and proms for specific to virtual care, and we're also looking at, we've already conducted one evaluation that had patient interviews in it with an academic partner, and we'd like to continue that process as well.
And as well, also with your context, Emily, you're also working with like non-patients, I suppose, in the quarantine facilities, so their experience as well.
Yes, we've had very positive experience come back from our model in the hotel quarantine system. We have a dedicated role now for patient experience or traveller experience. So we've tried to really create that whole hospital model within our hotel quarantine system. And it's quite interesting, the feedback we get, that people really do enjoy that telehealth, being able to have someone to talk to on the phone. We undertake daily phone calls as well from a nursing point of view to all of our travellers in, as well as a GP consultation for everyone there as well. So it's a lot of on the phone, but in fact, we find that's very helpful for people's mental health. There's been quite a number of studies already that have looked at telehealth within general practice, looking at patient experience and clinician experience. And so far, it's been very positive around, particularly for follow-up of care, and the ability for timely care as well, has been a real strong points that have come out in some of those, more and more being published as the year moves on.
Lucas, did you want to add to that?
Yeah, I think the question for us, because I agree with what Emily and Matt said, and overwhelmingly we're getting really positive feedback from providers and patients in all the consultations about long-term telehealth application. A question for us remains in video versus phone, and there's a little evidence, and there's a little bit of evidence, and there's also sort of logical assumptions that video is closer to a face-to-face experience, that's better, and as part of that, the changes that will come into effect on July 1st collapse some of the phone consults into just time-based level A's and B, while maintains the variety of different items for video consults and maintains the variety of telehealth consults over the phone for mental health, because there is evidence that those are well needed. But I think we need to see what's happening here and overseas to better refine whether there is actually a strong evidence base that video is better than phone, and whether the changes that we will see from July 1st before long-term telehealth is put in place will have an impact in that behaviour, because over the last year, an overwhelming majority of the telehealth consults have been over the phone, but it's unclear whether that's best care or not.
Thanks, Liz. And to extend on that, I suppose, have there been considerations for the possible inequities in terms of accessing internet in remote areas, or quality of the technology that goes with that, and how those inequities can be addressed as well?
Yeah, look, from our perspective, it's again a great question, but the answer to it is probably bigger than us. We're quite reliant outside of the hospital system. We're reliant on the big telcos and the rollout of the NBN across rural Queensland. We have had a noticeable improvement and a considerable reduction in the number of people saying they're having trouble with connection. So we certainly are aware that there's been a significant improvement in that space, but there's still areas, including some of the islands just off Brisbane, our capital city, that don't have connectivity. And the other challenge there is Aboriginal and Torres Strait Islander communities, extremely poor connectivity. So there's still some great challenges ahead that we don't really have an answer to, other than being aware of it and trying to advocate to the telcos and the Commonwealth around improving that connectivity.
Noting as well that concurring with all of that, but there's been quite an enthusiastic embrace of telehealth by Aboriginal health services. Remote communities were providing already a significant amount of telecare, with visiting doctors often being on site at different times, but still providing a lot of support, review of care plans, and review of pathology results while away in a major city. And this has really enabled that to continue. And that's why we need to look at whether there's specific adjustments, including for the video versus phone requirements for remote communities, or we maintain an exemption to the new requirement to have a face-to-face teleconsult, face-to-face consult in the preceding 12 months before a telehealth consult can occur for Aboriginal health services. So that is not a requirement for ACHOs.
Thanks, Lucas. And this, I think, will be the last question of the day, for this session. The question is aimed at Emily. What are your thoughts on the opportunities to translate the Medi hotel model of care to other hospital in the home services? And I suppose if that can be extended to the other panelists, so much innovation, how far will it be extended into other areas of care, in the next foreseeable future?
I think that's a really good concept to consider, how we can utilise all of this innovation that's been implemented into the home space. We certainly are keen to see how in the home hospital areas, particularly for community care. And we're very fortunate here that we do have a My Home Hospital program now in South Australia, which is based on a number of our DRGs that we then use for community-based care to reduce that length of stay within our tertiary space. So we're quite fortunate that we have that sort of model, and we're seeing how the two now sit together moving forward. But from a quarantine perspective, using Medi hotels is not a long-term sustainable model of care from a funding point of view. There needs to be innovation in the space, so we look at home-based models and look at tracking and how we utilise technology, facial mapping, facial recognition in this area. And we certainly, it's something we did explore in SA Health, and we had commissioned a product to do this for us, but unfortunately it didn't pass user acceptance testing, and we moved a different way forward. But it is something we do need to consider. How can we use all of these principles then in that home-based setting, and of course the telehealth requirements principles as well? Can we use them for that community care?
Matt, expanding innovation into other areas or extending your telehealth model?
Yeah, look, I mean, that's certainly always part of our agenda, is lots of horizon scanning, looking at where trends are going, what new technology is emerging that will allow us to further the spread of telehealth. For us, the essence of our program is equity. And so we're always looking for new ways to help people access the system. And that touches on what we've talked about today as well. You know, when we implement a new program area, we have to look at how do we need to shift the funding to suit this, and that requires a lot of back of house work with our purchasing division within Queensland Health to look at, well, okay, how are we going to shift our ABF methodologies and our purchasing incentives to allow for this particular new area of telehealth.
Lucas, final words for the day?
Look, it's almost commonplace now because we've seen it across all aspects of the health system. But the not to sound glee, but the benefits that the pandemic has brought on from not just the technology and early adoption of things like telehealth, but also a breaking down of silos perspective within departments and across departments, the state and territory and Commonwealth collaboration, intersectoral collaboration, and sort of that diffumination of the what's hospital, what's home, what's primary care, what's home-based care. I think it's here to stay. So I think we just need to keep harnessing that spirit, and I think vaccine rollout and the challenges with the vaccine rollout are giving us another thing to play with in this reform agenda. But I think we've made a qualitative leap in terms of moving our health system forward, and we just need to keep harnessing that energy.
Thank you, Lucas. And with those really positive words, unfortunately, I need to draw this session to an end today, and I would like to send a very sincere thanks to Matt Page, Dr. Emily Kirkpatrick, and Dr. Lucas de Toca for your fantastic presentations today. We're now going to have a break in the conference program. However, we've set up some networking sessions for those who are interested in meeting colleagues and like-minded individuals. The sessions running for the next hour has been split by themes, as it was during the concurrent sessions for day 1 and day 2 of the conference. You can pick a topic of your interest, and the session runs in 15-minute blocks. So head back to the timeline and click the theme you'd like to join. These sessions are not moderated, so please keep the code of conduct in mind. Have fun, and I'll see you back here in 1 hour. Thank you.